Hi, everybody. I'm Marc Rappaport. I'm a medical oncologist at Crystal Run. And this evening, thank you for joining. We are going to have, a sort of a brief discussion of slides. And I always like to have an ending with a lot of questions from you guys. So we're going to talk about genetics and cancer, sort of understanding the link between the hereditary cancers versus the sporadic cancers, how we test for the genetics, and sort of a surveillance plan for those that are at high risk due to their genetic findings. So really, what are and how do we explain the different types of cancer causing genetic changes? There's sort of three main categories, and I won't get so scientific, but there's something called point mutations, which, if you remember your DNA lectures, um, if there is a mistake in the DNA repairing, then you're going to have a mutation, which will then cause an abnormal protein to form, and that will hence increase the risk of a cancer. Then the second type is a chromosome problem, where a large chunk of DNA is either moved to another chromosome, or it is deleted, or it's duplicated. If any of those three take place, then again, you create either a protein that hence signals the cascade of different cancer pathways. And the third is gene expression, which is sort of a really exciting field. There's new technology that is called CRISPR, that is looking at altering gene expression with people who actually have known mutations. It's still very far away from current practice, but it's out there. So these are different genes that change their expression, then hence causes the cascade of cancer development. So as I said before, there are two types of ways that people can develop cancer. First is if it's hereditary, which is genetic, passed on from the family members, and that's up to 10%. And the second type is called sporadic, which is just, as I always tell patients, it's bad luck. And that's up to 90 to 95%. And those can be looked at as risk factors like smoking, aging, alcohol abuse. Those are independent risk factors for sporadic cancers. The four most common cancer syndromes that we find on our testing are the following. The most common that you guys probably have heard of is the BRCA1 and 2 mutation, which is called hereditary breast and ovarian cancer syndrome. That increases one's risk of breast and ovary in males. Well, females obviously ovary, but males is both breast and females breast, as well as an increase in pancreatic, melanoma, and sometimes uterine cancer. FAP is called familial adenomatous polyposis, or in English, basically, these are people and families that at a young age have thousands of polyps in their colon because of a gene called APC. And it's pretty amazing to see those pictures, and they are at a very high risk for colon cancer. It's a very small proportion of the population, but it definitely is a pretty fascinating, family history when you do see that. The treatment for people or families that have FAP is normally to remove the entire colon. The next is called Lynch syndrome. Lynch syndrome is a multi-organ risk. It is most associated with colon cancers and uterine cancers, but also you will hear families having stomach, pancreatic, and ovarian as well. And then the last, which is may not have heard of is called Li-Fraumeni syndrome. That affects what's called the P53 mutation. So the P53 mutation, just for some biology, is a tumor suppressor gene. It's actually a good gene that we all have. But when that gene is mutated, it cannot suppress the development of bad cells. And hence, you have development of cancer in really any area. And it happens very early on. You're talking teenagers, 20s, 30s, and almost every family member is involved. That is a bad actor because that is a major cancer regulator gene in your body. So we'll start with this pyramid to show that which gene mutations are overlapped, like I kind of discussed. So if you look at the bottom, we know that breast and ovarian carry the BRCA1 and 2, but breast also over the evolution of time. So say I started practice in 2008. Since 2008, we only were testing for BRCA1 and 2. Now we have like 45 genes on our panel, which is amazing. So breast, the more common mutations, which is in that panel, but we see positive for a risk for breast, is BRCA1-2, one called PALB-B2, CHEK2, and ATM. If any of those are mutated, your risk for breast cancer is precipitously high. The next is ovarian, and you see that there is some overlap with BRCA1-2. And then patients that have BRIP1 and RAD51, those two are newer. Say 5 years ago, we were just finding those and didn't know what the clinical significance was. But over the course of time, the companies that test these genes were seeing a significant increase in ovarian cancer. So then it was reclassified to a concerning gene mutation. Then colorectal is more like a Lynch syndrome. So let me just get rid of this. Is more like a Lynch syndrome. So those mutations for Lynch are these listed here: MLH, MSH, MSH6, PMS2, and APC. So I'm not going to ask you to remember this. There's not going to be any test, but it's very important that when you decide on your testing as the doc, to know which direction you want to go in to make sure that they target, the appropriate genes based on the diagnosis. Prostate cancer is important because people always think, oh, if a guy has prostate cancer, BRCA1 gene or BRCA2, they don't have a risk, but they do. So males with BRCA1 or 2 have a high risk of early stage prostate cancer, which does tend to be more aggressive, as well as male breast cancer. Other prostate cancer genes are HOXB13. And then pancreatic, though no specific gene has been found specifically for pancreatic, it's in the family of multiple different genes, as I stated earlier. So if you're BRCA, PALB2, ATM, any of those genes can increase your risk. And when I say increase, say the average risk of getting pancreatic cancer is about 0.5 to 1% in your lifetime. Therefore, that's just anybody that has any of these mutations, there's an increase percentage. I can't give you a definitive number because nobody has that number. It's just increased. So how do we test? So when I see a patient that is a new diagnosis, we have to then decide, are they a candidate for testing? We've come a long way in terms of what is covered now for the testing. If there's any uterine or ovarian patients, they're automatically tested and it's covered because that's the new guidelines. Any cancer in any patient less than 50 years old has to be tested and it's covered. Strong family history, first degree relative, multiple family members, has to be tested and it's covered. Personally, I try to be more aggressive with testing because I think knowledge is power, especially when you're discussing it with your future progeny and family. If for some reason it's not covered, the cost of testing ranges between $150 and $200. So it is not a significant, outlay of money versus what they charge the insurance, which is about $5,000. Um, and what you're looking for with the testing is if you know that somebody actually has a BRCA gene, you don't need to do the whole testing, you just do single gene testing. And then there's two, let's break it down. So maybe 15 or 10 years ago, we only were doing, say, 10 genes. Now, if you had that 10 years ago, but you come back to see me, I can test you with what's called the follow-up testing or the multi-gene assay to make sure that you get the whole testing done. If anything comes back positive, patients either speak to me to review what the options are, or they can have a professional meeting with a genetic counselor who specializes in cancer patients to give them the options based upon their specific mutations. So again, standard, surveillance. If Let's just break this down. If somebody, just in general, everybody should be following all of these three boxes: self exams, going for screenings with the doctors, going for your screening mammograms, colonoscopies. And then if somebody does carry a gene, then you go to the next level. You do high risk surveillance, which means periodic CT scan or MRI. You have to go to see a dermatologist more often, or you have to have imaging of your pancreas more often. So there's a bunch of things that should be done based upon what the gene mutation is. So this is just another kind of breakdown of based upon age, how you should follow up. This is, sort of a little bit vague, but I don't really break it down by age. I just break it down by if they have the mutation. Because we have conversations, a lot of women with BRCA, once they're over 35 years old or they've already had all their children, that's when we normally do recommend that they have surgery, or we offer surgery if they decide to do it. If they don't, then we recommend very high risk follow up with the breast surgeon, as well as a GYN oncologist. If they have Lynch syndrome, the recommendation is yearly colonoscopy. And if they have the Li-Fraumeni syndrome, not necessarily a whole body MRI. I would be more inclined to do full body CAT scan, probably twice a year. And if you fall into that pancreatic risk, if you have a gene that is in that category, like a BRCA or a Lynch, then you can consider a yearly MRI to evaluate the pancreas. So one thing about age and testing, and I always recommend this when I see young people who are interested in genetic testing. You want to think about the result of coming back positive and just knowing that if you are young and you don't have, private life insurance or private disability insurance, and it's something that you want to get, you won't be able to get private. You will always be able to get it through your employer, but not private because you're a carrier of a gene mutation. That's the only thing that can still be exclusionary, okay, is if you are a carrier of a genetic syndrome. So it's always important to just weigh those risks if you want to, acquire that private coverage before you get tested. Just food for thought. In terms of some limitations for screening, we have our mammo, we have our colonoscopy, endoscopy, MRI, MRCP. We have such good screening tests, but there are challenges. When we talk about, ovarian cancer, in general, most ovarian cancers are found when they're at least a stage 3 or higher. So there's no clear detection. We do not do any routine ultrasound. We do not do any routine tumor marker testing in the blood because that opens up a big can of worms. Many people actually do carry tumor markers in their blood because it's normal. So there's no screening test for ovarian. And like that gets into my second point. Some doctors will send their patients for a CA 125 for concern for ovarian, comes back high. They go through a multitude of tests, scares the heck out of them, and it's just their body. Their body makes the protein. If people have radiation exposure, so they had exposure by work, if they had exposure if from their basement, there's all different types of radiation that could increase risk, and therefore you may want to increase your screening. And then, like I did mention, if the genetic testing is not covered or other screening test is not covered, that is, of course, an issue. Sometimes they don't always cover an MRI for my patients, and I have to discuss then switching to do a CT. I tend to be pretty aggressive with my cancer screenings. So where are we at now for the future? I mean, right now, like I said, we're about 45 genes that we're testing with one blood test, just one blood tube for the genetic testing. But literally, I would say every 2 months, there's a new gene that's added to that panel. And a lot of this now is taken into, specific, risk algorithms by patients' personal and family history. We're doing actually now what's called liquid biopsy, which is looking for circulating tumor cells to see if one actually has those before an even detectable cancer. Now, that is not currently available. It is currently on trials. So it's a bit daunting to think about some kind of tests like that, but it may be the most preventative way to prevent long-term comorbidity and symptoms to be able to be diagnosed early than when one does present with symptoms. So this is a pretty exciting time in oncology the last few years in terms of genetics, treatment options. So, yeah. So that's where I'll conclude with the slide part.